Okay, I know I'm still admitting people, but let's go ahead and get started. So welcome everyone. My name is Melissa Withers and I'm the director of the APRU Global Health Program. And I am delighted to welcome you to the webinar on mental health among vulnerable populations in the context of COVID-19. So tonight we have 4 guest experts from 4 different economies around the world who are going to talk to us about their research and experience in mental health. So let me tell you first, I just wanted to, for those who aren't familiar with the APRU program, APRU stands for the Association of Pacific Rim Universities, and it's a nonprofit network of 60 universities in the Asia Pacific. It was founded more than 25 years ago, and I am the director, as I mentioned, of the Global Health Program, one of several programs. It's hosted by the University of Southern California. The APRU Secretariat is located in Hong Kong. Before also we begin, I would like to let you know, for those who are interested in and doing mental health research, Dr. Murphy and I, along with 2 other researchers, are guest editing a special edition on mental health care among at-risk populations in the context of COVID-19 for the International Journal of Environmental Research and Public Health. This journal has a very good impact factor. The deadline for submissions is October 1st of this year. We do have a number of fee waivers available for people in low and middle income countries, for students, people with lived experience. So, and also we have a quick turnaround time and the papers are being published on a rolling basis. So if you're interested, I would encourage you to submit your paper to that special edition. Great. Now let me go ahead. We have a lot to cover in the next 90 minutes or so. So let me introduce our speakers and let's go ahead and get started. Let's see, I need to keep letting people in. Okay, so our speakers are going to speak for about 15 minutes each, and then we'll also in between each two speakers have a couple of minutes for questions. So I'd ask our speakers to not go over 15 minutes so we have time for questions. For those who are in the audience, feel free to type your questions into the chat, and then I can ask the questions of our speakers. So our first speaker this evening is, or this morning, wherever you are in the world, is Shua Hua Hu, who's the director of the psychiatry department at the first affiliated hospital at Zhejiang University School of Medicine in China. He graduated from Zhejiang University School of Medicine and finished his clinical training program there as well. He's a research visitor studying in the psychiatric department at Columbia in 2012 and has published more than 120 papers in high impact journals. His research focuses on the microbiome brain axis and neuroimmune mechanisms of bipolar disorder. Please check out his full bio on our website. The full bio is there. So thank you so much, Dr. Hu, for joining us. And I'd like to invite you to give us your talk.
Okay, thank you, Ms. La. Hello, everyone. I'm Hua. It's my pleasure to be here and take a lecture about the mental health issue. Firstly, I share my PowerPoint. So our session topic is mental health among a vulnerable population in the context of COVID-19. So based on our previous experience on fighting COVID-19, so my topic is global challenge of mental health services for the people during the COVID-19 pandemic. It's the latest statistic of COVID-19 from the WHO. So we can see around the world, the confirmed diagnosis cases was more than 537 million, and the accumulated cure we can see deaths has reached about 6 million cases. So we can see the COVID-19 has affected the population around the world. The global prevalence and burden of depressive and anxiety disorders in 200 countries and territories in 2020 due to the COVID-19 pandemic. The study shows us the COVID-19 pandemic increased an additional 53 million cases of the MDD globally, and the total prevalence of depression and the total prevalence of anxiety disorder has reached a high data. The GBD, we know is the global burden of disease, injury, and the risk factor study initiated by the WHO, show us the data of the COVID-19 has reached a high level. So we can see the details. Before adjusted for the COVID-19 pandemic, the estimated global prevalence of major depressive disorder in 2020 was 3,400 cases per 100,000 population, equivalent to 193 million people. At the same time, we can see the change in the prevalence of anxiety disorders after adjustment for the COVID-19 pandemic in 2020. We can see 3,800 per 100,000 population, which is equivalent to 298 million people. So we can see the major depressive disorder and the anxiety disorder is the major mental health burden in the global population. Yeah, we can see the COVID-19 pandemic has induced a mental health burden in special individuals, especially the medical care workers. As our study, we collaborated with the colleges in Wuhan Hospital. We carry out an investigation to analyze the effect associated with mental health outcomes among healthcare workers exposed in COVID-19. So the study was carried out in the first 3 years in China. In 2020, we can see the healthcare workers seeks to, in the first 3 years in 2030, the healthcare workers has a heavy burden. We can see some risk factors associated with their mental health problems. The emotional strain and physical exhaustion when caring for the growing numbers of cases. Caring care co-workers who may become critically ill and sometimes die. Shortage of PPE, concerns about infecting family members. So many the risk factors induced their severe mental health problems. It's the PPT, the slides show us the major results. We find a considerable proportion of participants reported symptoms of depression, about 40%, anxiety, 54%, insomnia, 34%, and distress, 71%. And we also find the nurses, women, frontline healthcare workers, and those working in Wuhan, China, reported a more severe degree of all measurements of mental health symptoms than other healthcare workers. So in this survey of healthcare workers in hospital, equally with fever clinicals or words for patients with COVID-19 in Wuhan and other regions in China, participants reported experiencing psychological burden, especially the special individuals in front line in Wuhan hospital. So other meta-analyses show the prevalence of PTSD after infectious disease pandemic in the 21st century during COVID-19. We can see healthcare workers had the highest prevalence of PTSD, followed by effective cases, and the general public mean 17%. The risk factors including individual, family, and social factors, pandemic-related factors, and specific factors in healthcare workers and patients for post-pandemic PTSD. So in the current the situation, so we should facing the challenge of the mental health problem. More and more evidence shows the neuropsychiatric sequelae have developed in some survivors after COVID-19 infections. Such a situation has faced after SARS, we also have found some survivors has neuropsychiatric sequelae, and frontline healthcare workers and first responders has been traumatized in their roles, and the people are stricken with new anxiety or depressive disorder, and those with pre-existing mental health problems such as MDD patients, bipolar patients, or schizophrenia patients has seen their condition worsen. So how to handle such a challenge? In the first year, Chinese experience shows some the evidence about how the people handle mental health problem in mental workers. So we can improve the local government the policy. Our Chinese medical colleges send medical workers from the other province to Wuhan, and a general hospital and the online platform services, and we can give timely psychological intervention teams to provide the necessary medical services. And online mental health services developed in China during the COVID-19 outbreak. So our Chinese colleges give us some experience in the first 2 years of COVID-19. Many mental health consultants, they provide the mental health services for the individuals of effective cases or the suggested cases of the population. Other Chinese experience focus on the psychological intervention for people affected by the COVID-19 epidemic. Such overall planning is not adequate, wasting mental health resources and failing patients in terms of a lack of timely diagnosis and poor follow-up for treatments and evaluation. So collaboration between community health services and mental health care institute in some provinces and cities, China, has been decoupled. And we can give the evidence-based psychological interventions such as CBT or ITP give the effective people. So we can see around the world, COVID-19 mental health challenges is following such issues. Irritable treatment models. We should give the mental health services for the vulnerable population. We should together coordination need for trauma-focused treatment, online services, COVID-19 survivors. We should focus on them and give the follow-up medical services and proactive outreach. In our hospital, based on our the experience on fighting COVID-19, we published a paper, handbook of COVID-19 prevention and treatment. Our group write the experience of mental health services. The handbook has main contents: epidemic prevention and control technology strategy, diagnosis and treatment plan for critical illness, and nursing methods and experience. This handbook can download from the Nature website, has translated in many the language. So our experience is widely spread overseas. From March to April of 2020, we have connected the video conference with 26 countries to deliver the experience of fighting against the epidemic. In our hospital, we completed the 2 old age lung transplantation. Yeah, the peri-operation mental evaluation and intervention of lung transplantation was provided by our group. And we also completed the investigation for the cognitive function in recovery COVID-19 patients. In the study, we included the 29 gender, age, and education matched health countries, and some patients recovered from COVID-19. We used some psychological tests to measure the cognitive function in the we find that some patients has impaired cognitive function after the recovery from the COVID-19 infection. And the level of cognitive function was associated with the level of inflammatory cytokines. And so in conclusion, our finding indicated the potential cognitive dysfunction in patients with COVID-19, especially the sustained attention, which was possibly linked to the inflammatory level as indicated by CRP. So, we should provide some the strategy for the mental health services in pandemic. We should give more timely prevention and intervention policy. Before infection, early detection, timely monitoring, urgent public health response, and comprehensive management, health education, and promotion is necessary. Strict individual protection, health lifestyle, regular treatment, and alternative online consulting and intervention of existing disease is also necessary. And in clinical management, we should provide adequate and experienced and psychiatrists and psychologists, training for healthcare staff, attention to specific magnificent target treatment, progress, adjust the diagnosis, and treatment plan with comprehensive consideration. So in summary, we can see increasingly weight on the global psyche as it exposed the structural inequities, intensified long-standing mental health access challenges, and vastly increased the number of individuals in need of treatment. And mounting studies show the association of mental and neurological disorders, both pre-existing and subsequent, with susceptibility, illness severity, and mortality of COVID-19. Early detect and intervention for neurological and mental health, mental disorders are urgently needed to control the morbidity and mortality of COVID-19 pandemic. That's all. Thank you.
Thank you. Thanks so much. Really interesting. I have a number of questions. I know other people do too, but we're going to hold them until we get through our next speaker. So thank you, Dr. Hu. Our next speaker, I'd like to introduce Dr. Jill Murphy, who's a research associate in the Department of Psychiatry at the University of British Columbia in Vancouver, Canada. She's also the executive director of the APEC Digital Hub for Mental Health. Her research expertise is in global mental health with a focus on integrating evidence-based mental health care into primary care and community-based settings, workplace mental health, equitable access to digital mental health care, factors influencing the implementation and scale-up of mental health programs in LMICs, and equitable stakeholder engagement in global mental health research. She's also co-lead of the UBC Research for Mental Health Equity in the Asia Pacific Digital, or our REMAP-D research cluster. And so please join me again in welcoming Dr. Murphy, and please read her full bio on our website. Thank you so much for being here.
Thank you, Dr. Withers, for the introduction, and sorry, I've gotten ahead of myself here, for the introduction and for inviting me to talk today. And thanks, Dr. Hu, for a really interesting presentation as well. I'm really happy to be here this evening, my time, and this morning for many of you. And my talk is called Technology and Equitable Access for Mental Health Care in a Post-COVID Asia-Pacific Multi-Stakeholder Perspectives. So this study, the first part of my presentation title is also the name of the study that I'm going to present on today with the acronym TEAMCAP. And this study was a response to the rapid transition to digital health that took place during the early days of the pandemic. So when we were discussing the proposal for this study, we recognized both the opportunity presented by the rapid rollout of digital health and also the risks of further exacerbating mental health inequity among the most at-risk populations. So this led us to develop the TEAMCAP study, which was subsequently funded by the Canadian Institutes of Health Research. And as you can see, the study team is made up of representatives from 8 countries. It's led here at UBC by Dr. Raymond Lam, myself, Dr. Erin Mahalik, and includes team members including researchers and policymakers in Australia, China, Chile, Malaysia, South Korea, Vietnam, and the US, including Dr. Withers and Shirley Saker, who's a MSc practicum student who's been helping me with the analysis that I'm going to talk about, or the results that I'm going to talk about today. So just some very brief background regarding mental health, COVID-19, and equity, and sort of the impetus for this study. So as we all know, the impacts of the pandemic have been felt universally, but not equally amongst populations. And we see the interplay of vulnerabilities which may increase the risks of both negative mental health effects and exacerbate barriers to care access. We also, we also know that there's been limited research on equity in e-mental health in the context of the pandemic and also in general. So this has been a bit of a catalyst to increase more research on digital health and equity. And we saw a paradigm shift to digital health evidence, which is evidence-based. So we've seen for a long time the evidence base supporting the use of digital mental health interventions, but we know that this shift, especially as rapidly as it took place in the early days of the pandemic, may leave some populations behind. So the objectives of the TeamCAP study are, first of all, to identify the mental health needs and barriers to digital care for at-risk groups in the context of the pandemic in the APEC region, and to identify best practices and advance recommendations for providing equitable access to digital mental health care during the pandemic and also beyond. So I'd like to quickly describe what we mean when we refer to digital mental health technologies. Many of you might be familiar, but just so we're all on the same page, in the context of this work, when we refer to digital health, we're referring to a broad range of approaches. So this may include video conferencing, including Zoom consultations and things like that, text-based interventions using live chats or SMS, mental health apps that you can access on a smartphone, and also web-based programs that are offered both on computers and smartphones. So we're talking sort of across the broad range of digital mental health technologies. So TeamCAP is a mixed methods study that consisted of qualitative online consultations and also an online survey. But today I'm just going to be talking about findings from the qualitative component as we're still finalizing the survey analysis. So these consultations actually took place quite early in the pandemic, relatively speaking, and took place between October and December 2020. We consulted with policymakers, healthcare providers, people with lived experience, as well as people working for social services and community-based organizations that serve people with lived experience, who are often also working in those roles, often have lived experience themselves. And we had participants from Canada, Chile, Malaysia, New Zealand, the Philippines, Russia, South Korea, and the USA. So we asked participants to identify populations that have a higher risk of negative mental health impacts related to the pandemic. And while there's many population subgroups, healthcare workers being one of them that Dr. Hu spoke to, that often experience intersecting vulnerabilities, we can really identify three overlapping categories of risk factors based on the consultations. So populations with existing or pre-existing or intersecting vulnerabilities were identified as a broad group having increased risk of negative mental health impacts. And these might include LGBTQIA+ folks, youth, migrants, seniors, people with existing mental illness, and others. And as you can see on the slide, a policymaker stated, people who previously experienced health and social inequities are the people who are hardest hit. Next, we have people experiencing isolation who are also identified as having an elevated risk of negative mental health outcomes. And in the context of the next quote by a person with lived experience, they describe the isolation that many seniors were facing. So they say, I think seniors who live alone experience a lot of isolation. You know, they can't go to the community center anymore. They can't go and get coffee with their friends. They can't go to church. They're stuck at home. They can't see their family members, their grandkids. So I think the seniors are specifically very isolated and suffering more from mental health issues because of that. And finally, people living in poverty or people with economic vulnerabilities were also considered to be at a higher risk. And as described by this policymaker, may become an increasingly vulnerable and at-risk group. And as we currently see rising rates of inflation and food costs, fuel costs across the world, this is even more striking. So this policymaker said, this has created a group of new poor. The issue is that in the Asia Pacific region, poverty is projected to increase for the first time in 20 years. And it's estimated that almost 38 million will be pushed into poverty or are already on the borderline. So that's going to be a huge vulnerable population. We also asked about specific populations that are specifically experiencing barriers to digital care access. And accessibility for people with disabilities was identified as one challenge, as illustrated in this quote by a member of our People with Lived Experience consultations, who said, "People in poverty who don't even have a computer or a phone, yeah, I see it all the time in my work, because we deliver all our counseling services virtually. And so many people, they can't even access our services because they don't have a laptop or anything that's required." Rural and remote populations, including Indigenous peoples, are also identified as experiencing barriers, often related to poor availability of internet infrastructure. And so in this case, we see a healthcare provider saying, in Malaysia, we have seen that the people that really could not get the digital mental health and telehealth care are people who stay at the rural areas. They could not get the internet lines as good as people who stay in the city. So if we want to provide the virtual mental health over there using the digital technology, it's going to be very limited access for them. And finally, a lot of population groups and people were facing interruptions in their usual care or support systems. And these also include youth, especially LGBTQIA youth came up frequently as an at-risk group under this category, people with severe mental illness and people with disabilities. And this quote described potential barriers experienced by people with severe mental illness. And this healthcare provider said, "I think a lot of people who were having care before, they stopped having it. I also imagine that there are some kinds of care that are very difficult to do online. So let's say someone with schizophrenia goes during the day to have activities with other patients, and so they can be occupied and have social interaction. I'm not sure that can actually be done online, and maybe they'll have a short visit or something, but there are some things you really can't do online." We also asked participants to identify key access barriers. And again, accessibility for people with disabilities was identified as a challenge. And so here, a person with lived experience says, "You have individuals with hearing impairments that may not have the right devices to do an online meeting, and those that you can't log in without their support worker or family member right beside them to use devices." So there's an accessibility issue there. Cultural and linguistic appropriateness is also an accessibility barrier, including for ethnocultural minorities, migrants, and Indigenous populations. And this policymaker said, "Often the programs that are delivered online are based on evidence-based techniques like CBT and counseling, but they're often developed really within a Western model and don't resonate with all cultural groups that live in Canada because we are quite a diverse population." So this was a policymaker from Canada. We also found that access to digital mental health care varied by the type of modality. And so this was an interesting quote by a member of the Person with Lived Experience consultation, who said, "When we look at nonverbal virtual care, so things like live chat or texting, there just isn't enough technology to facilitate that piece. So for example, on the phone where a young person connects to a counselor who speaks English, and then if that person is speaking Arabic, we connect to an Arabic speaking interpreter and then facilitate that three-way conversation over the phone. That's doable, but there isn't enough technology to do that for text or live chat." And finally, privacy. And in this case, there was a lot of discussion about privacy among people who live in either very small accommodation or who have had a lot of family caretaking responsibilities, especially during the sort of more lockdown periods of the pandemic. Being able to openly speak to counselors or access mental health services from home. And this one person with lived experience says, "How do you navigate being able to be open and transparent when someone is always 10 feet away?" So finally, we asked participants to identify resources and actions needed to improve access to digital mental health care among vulnerable and at-risk populations. Given the rapid shift to digital health in the early days of the pandemic, many participants described feeling unequipped and unprepared in terms of best practices for rolling out and scaling up or promoting access to these options. So this policymaker from New Zealand stated, "I'd love to see a whole suite of complementary digital services that can enhance access at a population level as well as a targeted way at an at-risk group level. And to do that, we need to really have a clearly defined framework, and we need to be investing over the medium and long term into the things that support that framework. But without the framework, those things don't happen. Unsurprisingly, steps to promote access and affordability are also needed, and these can range from ensuring that digital care options are low or no cost to patients, promoting culturally appropriate care, and creating more access to digital devices and internet access. So on this last note, this person with lived experience from Canada said, one of our colleagues who works in the North, their local band supplied all the kids with tablets not that long into COVID. So they had access. And so, let's call it as it lays. The haves have the ability to provide for the have-nots, meaning the big companies like TELUS and Bell, which are Canadian telecom companies, they can throw Wi-Fi anywhere and they want during this, but I haven't seen it. But it's such a simple thing. It's such a simple thing. And finally, increasing awareness about digital mental health care, including about the effectiveness of digital health, as well as how to access it, is also essential. And so this policymakers quote sort of underscores some of the challenges with awareness around digital mental health care. And they say, the number one thing we learned when we were asking patients and practitioners around, why didn't you use e-mental health? It was really around not only did they not know the services existed and or the quality of the evidence, the number one thing was that they thought it didn't work as good as in person for whatever they came in for. And so it's also some myth busting. So I've presented at quite a high level findings from the qualitative component of this study. And as I previously mentioned, we've also conducted a survey that's going to inform these results. And in the consultations, we also asked about delivery side barriers, for example, from the perspective of healthcare providers and community-based service providers, what some of the delivery side barriers are. But for the sake of brevity, I haven't included in this presentation. So please stay tuned for future publications and reports. But nevertheless, we can make several recommendations based on these qualitative findings. And the first is of course, to develop evidence-based policy and practice guidelines that take into account equity and the context of delivery. So one size doesn't fit all. Context is very important. And any sort of framework and guideline related to digital health has to consider equity considerations across intersecting types of vulnerabilities. Second, it's essential to engage service users from diverse communities in the development of e-mental health or digital health programs and services to understand their needs and to identify any potential barriers that they might encounter when accessing these services. Also to invest in accessibility via things like cultural appropriateness or safety, multiple language options, diverse platforms. So we saw the quote about sometimes what's able to happen on a video chat isn't for someone from an ethnocultural linguistic minority is impossible or more challenging during a text-based chat. And also usability options, including for people with disabilities. There's also a real need to expand internet and device availability, including to underserved communities who live in rural or remote areas, or people living in poverty, even in urban areas. And this including through public-private partnerships. So I read one quote about the First Nations Band Council giving access to devices. And there were other examples in our interviews about community-based organizations providing access to things like Wi-Fi and devices, but very little around the corporate sector, the telecom sector. So engaging with that sector, as well as increased government investment, is really important. And also to increase awareness of the availability and effectiveness of evidence-based digital mental health options. So there's a lot out there in the world, in the digital space. So first of all, increasing the understanding of what actually is evidence-based, and also just making both providers and patients aware of their availability and their effectiveness is really essential. So as we all know, the rapid response to COVID-19 via the rollout of digital mental health in the early days and the ongoing availability of digital or hybrid models of care present an opportunity to advance digital mental health equity. The pandemic has called broad attention to the need for enhanced mental health and psychosocial support, and has led to an accelerated use of evidence-based mental health care, which is a bit of a silver lining. It also has underscored the need to address the social and structural determinants of health as they relate to mental health and mental health care access. So in 2020, Crawford et al. Advanced a digital health equity framework that guide more measurement-based approaches to assessing digital health equity. And so research in this area is really essential, especially with the unprecedented paradigm shift to digital care that's taken place under this pandemic. So in the last few seconds of my talk, I just wanted to mention this initiative that's led here at UBC that Dr. Withers mentioned in my intro, and includes partners from across the region, including some people that are on the call with us today. So the Research for Mental Health Equity in the Asia Pacific Digital, or REMAP-D, Research Excellent Cluster is made up of a group of interdisciplinary researchers and people with lived experience from UBC and across the region. And our vision is to take an interdisciplinary, intersectoral, and inclusive approach to research and translatable action on mental health equity in the Asia Pacific, focusing on digital technologies. And we always welcome new members from across the region, so please do feel free to reach out to me if you're interested in getting involved. And just in closing, I'd like to acknowledge everyone who supported this work, including our funders, including research assistants and practicum students, and my PI, Dr. Raymond Lamb. So thanks very much, and I'm really happy to answer any questions that you have.
Thank you. Thanks so much, Dr. Murphy. Very informative talk about a really fantastic study, very comprehensive. So I have first question is for Dr. Hu that says, I'm wondering what role increased mental health awareness due to the pandemic has played in the variability in the prevalence estimates of depression, anxiety in Southeast Asia, for example. For example, the GBD studies estimates of depression prevalence in Indonesia in adult populations prior to the pandemic was informed by only a single study undertaken in an Indonesian geographic region, and the trend is the same for others. So has this increased awareness just led to more research, or is the prevalence, truly increased?
Sorry? Yeah, I hear in the first the sentences. Please clearly the questions.
The question is, the increase in prevalence of depression, is it simply because there's increased mental health awareness due to the pandemic? And previously, we were using estimates of depression prevalence based on like one single study in only one geographic location. So how has the pandemic and this increased awareness shifted?
Yeah, GBD study is very important. So from the WHO study, we can see the global the medical burden, the changes. As we know, the different countries has faced different the medical services and medical problems. So there's some imbalance between the different countries. I know, because in some countries which has low medical services, maybe they facing the more severe medical burden, and some of the development countries and other countries who provide the strict the policy maybe has a lower medical burden. So I think in general, the medical burden is increased in the past 2 years. The slides show us that we should focus on the mental health, the challenge Yeah.
Wonderful. Thank you so much. And a question for Dr. Murphy. Has the pandemic caused us to, or forced us to use digital mental health services? Do you think that this trend is going to continue now that the pandemic is ending?
Well, let's hope the pandemic is ending. Yeah, I think that's a great question. I don't think that everything will stay almost entirely digital. I think what the pandemic has done has raised awareness about the potential of digital technologies. And I would sort of anticipate that we'll be looking at more of a hybrid model. So I think those of us who've been working in digital mental health for a while, you see the evidence base, and there's been a real gap between, as there is with so many things, there's been a real gap between evidence and uptake. And so I see this as an opportunity to improve uptake and access to digital mental health technology. But of course, we know that many people prefer face-to-face interactions, that digital mental health may not be appropriate for all people or all situations. But I think it's also, when it's done right, it can really increase access, for example, for people who are not in close geographic proximity to their healthcare provider, in contexts where there may not be quite a lot of mental health specialists and things like that. So I think it has a lot of potential, but I would definitely say more of a hybrid model than just sort of an entire shift towards digital mental health.
Thank you. Thanks so much. Thank you to both of you for those really wonderful and interesting talks about your research. Thank you for sharing your research with us. So I would like to move now to our third speaker for this evening. So it is my pleasure to welcome Benny Prawira, who is a social health psychologist and global mental health advocate. He's been working in the field of community-based mental health advocacy and suicide prevention, youth and minority mental health in Indonesia since 2013. Besides working in the community Into the Light Indonesia, he also serves on the Southeast Regional Lead in Global Mental Health Peer Network. And he's been on a lot of advisory boards for mental health and suicide prevention research. And please, again, take a look at his full bio on our website. Thank you. Join me in welcoming Benny Prawira to speak to us.
Thank you, Melissa, for the opportunity. Good evening and good morning, everyone, across the world, wherever you are. Thank you so much again for today, the opportunity as the only NGO representative here. So I'm glad that I can represent some of my work, some of our work as community-based organizations. We've done a lot on the research on suicide prevention in Indonesia. So within the next 10 or 15 minutes, I'm going to present you our latest publication, our latest paper on vulnerable populations condition on Indonesia, especially on loneliness, self-harm, and suicide ideation during pandemic last year in 2021 in Indonesia. So for the background, the first reason why we focus on suicide and self-harm in Indonesia is because the research on this topic is still largely clustered in high-income and upper-middle-income countries. Within Indonesia itself, suicide is still a taboo and rarely explored as a research topic. And the second reason is we do not have any suicide or self-harm rates among vulnerable groups, which identities are also erased, stigmatized, and rarely explored in any public discourses, even research in Indonesia. Even though previous systematic analysis of suicide mortality burden found that the rates of suicide mortality among general population in Indonesia was very high. It is so high that it influenced the average suicide rate in Southeast Asia region. That happens among the general population. But can you imagine what happened around the vulnerable populations when we do not have any data? And The third reason is we also know that COVID-19 pandemic exacerbated existing inequalities, which usually associated with higher mental health issues. As Dr. Murphy has mentioned before, the COVID-19 pandemic hits us all universally, but not equally. Then what what happened in Indonesia regarding the inequality itself? I will give some examples. One of my biggest concern right now is the homo and transphobia have been very rampant since 2016 in Indonesia, and this has led to many issues in health outcomes and access for queer people. Another example is people with disability are rarely accommodated in public spaces before pandemic. Even after we have such an international event G20 in Indonesia, we still have some venues that are not really friendly to people with disability. So such situations, of course, have become worse during pandemic, and several vulnerable populations needs are neglected. Meanwhile, we also want to focus on loneliness because it is also known as the major issue during pandemic, and it is also one contributing major risk factor for suicide globally. Thus, this research aimed to explore the loneliness, self-harm, and suicide ideation during the COVID-19 pandemic in Indonesia that once had the highest COVID-19 fatality rate in Asia. So these are the methods that we gather the data with the non-randomized sampling method by utilizing online forms. The survey link itself was sent through the mailing list of Internet Indonesia and change.org Indonesia to organizations who conducted this study. We also asked the vulnerable communities member to share the link to their social media accounts to improve the inclusion rate of vulnerable populations. Participants, thank you for the trigger warning, Melissa, the readers. Okay, so the research aim, we also asked the vulnerable community members to share the link. So we asked for their involvement. The participants criteria are citizens of Indonesia, aged 18 years or older, and live in Indonesia during COVID pandemic. So there are 5,211 participants collected from 25th of May to 16th of June 2021. We also collected all of this. Oh wait, it seems to freezing. Oh no, this is freezing, sorry. Okay. Please wait a moment. Oh, the freezing. Okay, so these are the demographic informations that we are trying to collect. You can see those who are in yellow colored box are the identities and they're usually marginalized in Indonesian context. And then as you can see, we try to include everything from ethnicity, religion, sex/gender identity, sexual orientation, HIV status, and disability status to make sure all minorities and vulnerable populations are captured. And these are the measurement tools that we use for this study. For loneliness, we use UCLA loneliness scale, 6 items that has been adapted to Indonesian version. And the PHQ-9 single item, specifically the number 9 from Indonesian version that asks for about the suicide and self-harm ideation. So this is the major findings. As we can see how almost all of us are impacted by the COVID pandemic here. Especially we can see that how 98% of participants reported feeling lonely during the pandemic. And then, however, we can see that this is also one of a concerning rate of suicide and self-harm ideation during the pandemic is almost more than 1/3 of the total participants, and this is a quite high number that we rarely have before the pandemic. Okay, so as we can see, even though it is such a high rate among general populations, among all participants, they capture in Indonesia. However, there is an unequal distribution of loneliness intensity and self-harm and suicide ideation rate and intensity. Some groups have higher rate of loneliness highlighted in yellow, such as people living with HIV and people with disability, and other groups have lower loneliness intensity. They are highlighted in green, such as those who age 38, 35 years old and older, and those who work as civil servant or police military members. For self-harm and suicide ideation, several groups with have higher rate and intensity are non-heterosexual people, people living with HIV, and people with disability. While there are those with lower rate and intensity of self-harm and suicide ideation are people aged 35 years old and older, and those who work as civil servant, police, military members, and those who earn more than 843 USD per month in Indonesia. And these are the variables and groups associated with higher risk of self-harm and suicide ideation. We can see that the specific variable that contributes a lot to the higher risk, who has higher odds of self-harm and suicide ideations, are those with loneliness intensity. So the other groups, we can see that these are the vulnerable populations that live in Indonesia. They become vulnerable, of course, because they have different challenges. For example, for young people, it's because they are in transition to adulthood, but now in pandemic times, they also have to transition in online learning or online working environment, and it becomes a double burden of a transition for them. For those who live in Java Island, even though Java Island is a center of governments and everything in Indonesia, but it seems that probably those who live in Java Island being most impacted by COVID-19, because the Java Island has the highest infection rate, while there are still huge access inequity to healthcare in Java itself. Meanwhile, unemployed, the student and freelancer groups also have these higher odds of suicide rate, might be due to the pressure and anxiety related to their job status. It got worse because the pandemic heavily impacted them with less job opportunities and more economic challenges. Minority religious background might have this higher odds of self-harm and suicide due to the lack of community support. Besides, they can only use online platform for their community prayers. Meanwhile, compared to the majority religion, which is Islam in Indonesia, they usually utilize a lot of loudspeakers around the neighborhood, so they can announce their religious teachings, preachings, and community services, providing them with a sense of connectedness to their religious community. While women also found to have higher odds of self-harm and suicide ideation due to more life challenges. In Indonesia, we have a very strong patriarchal society. They might also have faced more domestic violence during the lockdown. And then for non-heterosexual and transgender people, they have also been demonized and pathologized even by healthcare professionals in Indonesia long before pandemic happens. In COVID situation, transgender individuals had also more difficulties to access the public aid and services as they have no citizen identity card. So when it comes to the people with disability, they also face more challenges as there is lack of adequate support for COVID-19 health protocols and public services. For example, the COVID-19 health protocols is announced on daily basis in Indonesia, but they rarely use the sign languages and other physical disabilities are really ignored as well. So there are also of course, the limitation of the study, even though we had successfully unveiled inequity in Indonesia regarding the suicide rate and self-harm. Those people who live in Java Island is overrepresented in our participants column. So yeah, we need to do more, especially for those who live outside in Java Island for the next study. Some minority group members were relatively small, especially like people with HIV and transgender people. It's kind of hard to reach them because they sometimes they are not really engaged with the online communities as well, and because they are relatively small, then maybe insufficient for statistical analysis. And the sex and gender question were mixed into one question due to the public negative sensitive attitude toward gender non-conformity. So we had to choose one question only, because if we separate them into two questions, that will create a confusion around the participants, and that will create a lot of questions from them. And the single item from item 9 from PHQ9 doesn't seem to be pretty adequate to measuring suicidality, because it can capture both suicidality and self-harm. So we need a stronger, we need a better measurement tools for the next studies. And the results were also limited to the data collection period, because it was close to lockdown period. I don't think the result is quite applicable in other time during the pandemic. So this is the conclusion. For in 10 people in Indonesia may experience self-harm and suicidation during COVID-19 pandemic 2021. And the likelihood of experiencing self-harm and suicidation were higher among these vulnerable populations and those experiencing loneliness from social isolation. And yeah, socio-economic inequity might play a role in this gap as well. Thus, we highly recommend that mental health treatment and suicide prevention program during and post-COVID should prioritize these high-risk groups. Programs should also be tailored by involving them to make sure that their needs, challenges are addressed and prioritized during the program development. So thank you for listening on that.
Thank you so much. That was that's really important research that you're doing. So I'm so glad that you agreed to be one of our speakers. And I know we have questions, but we're going to hold them till we finish with our second speakers and a presentation. So I would like to welcome Jane Fisher. Dr. Jane Fisher is an academic, clinical, and health psychologist and Finkel Professor of Global Health in the School of Public Health and Preventive Medicine at Monash University in Melbourne, Australia. She is co-director of the Division of Planetary Health and leads the multidisciplinary Global and Women's Health Research Group of academics, research higher degree students, and professional staff who undertake research in Australia and the Indo-Pacific region. She has a long-standing interest in the social determinants of mental health and well-being across the life course, and of how these can be addressed in public health approaches to mental health promotion and the prevention of mental health problems. So please take a look at her full bio, and thank you, Dr. Fisher, for being with us today.
Well, thank you very much indeed for the invitation. And thank you too to the previous speakers who've set the scene so richly for the impact of the pandemic on the psychological functioning of whole populations as well as subpopulations. The research I want to talk to you about was conducted in Australia, but I think it will have a lot of synergies with the research we've heard about in other countries. We initiated this research at the beginning of the pandemic, trying to understand what the impact of the restrictions associated with pandemic management might be for the mental health of the population as a whole. And as we've already heard, these are unlikely to be equitably distributed across the whole population. At the time we initiated this work, there were no Australia-wide national population data. So what we tried to do was understand the experiences of adults in Australia during the early phase of the pandemic, and then 6 months later. And we wanted to estimate the population prevalence rates of more severe symptoms, understand which groups were quite protected and had retained optimism, and see to what extent their experiences were influenced by experience of the virus itself, loss of a job, being very worried about contracting the virus, and experiencing the restrictions as having a very high adverse impact on their lives. And we were able in Australia to conduct a natural experiment because our restrictions varied state by state. So we were able to compare at a later period in July and August 2020, whether there were differences in the mental health burden in the state with the most severe restrictions compared to those where the restrictions were not as severe. So we conducted 2 anonymously completed online surveys, one in April and May and one in July and August 2020. The survey instrument included measures we've already heard about today, the PHQ-9 and the GAD-7, as well as study-specific questions. So in total, about nearly 14,000 people completed the first one and close to 10,000 the second one. They represented our whole population of women, men, and people who didn't identify as either female or male, a very wide age span, and all socioeconomic positions, and they were drawn from all states and territories. So what we found was that direct experience of the virus increased dramatically in that time period. The number of people, who'd lost a job varied from about 1 in 10 to a bit lower than that, but people's worry about contracting the virus and increased between the first and second surveys, but experiencing the restrictions as having a highly adverse effect on their lives began to diminish. So quite a mixed picture. As you know, it's quite difficult to find comparative population-based data to know to what extent the estimates we found about the prevalence of clinically significant symptoms, how much that varied. But we've collected all the population-wide studies that have used these measures, and you'll see that the prevalence of clinically significant symptoms at non-COVID times varied between about 3 and 10%, and of anxiety about 6%, and about up to 2% of people reported having had thoughts that they wanted to die or contemplated self-harm recently in the last 2 weeks. But what we found, and I think this mirrors what we've already been hearing about, was there was a huge increase in the population-wide prevalence of these experiences. So nearly a third experiencing clinically significant depressive symptoms, 1 in 5 anxiety symptoms, and like the data that Benny has just presented, really a very highly increased prevalence of people saying they felt deeply despondent and were having thoughts that they'd be better off dead. I think also of concern was there was this increase in anger and irritability. And by the second survey, we found that these had not diminished. People were still experiencing very high prevalence of these experiences as the pandemic continued. So overall, there was a population-wide increase, both in mild symptoms, in moderate symptoms. But despite these, quite a high proportion, 1 in 5, still experienced significant optimism. These interacted with people's circumstances. So we examined whether these were linked to experiencing the virus directly, having lost a job, etc. And we found that there were many significant associations with these circumstances. So as an illustrative example, there was a 50% higher likelihood of having clinically significant symptoms of depression among people who lost a job because of the pandemic. And there was a nearly doubling in the experience of thoughts of self-harm or being better off dead among those who said the restrictions were having a terribly adverse effect on their day-to-day lives. So we were able to examine the difference between states which had very high restrictions, including in Victoria, which was the state where we're located, compared to states where the restrictions were less severe. And we found that in all the dimensions, except thoughts of being better off dead, there was a much higher likelihood of having these when the restrictions were very severe compared to the states where they were less severe, and that optimism was lower. So this was direct evidence that it was the restrictions themselves that were having an impact on mental health, as well as the fear of contracting the virus. So in summarising these here, the proportion of people with no symptoms in population data before COVID, generally around 80%, but this had fallen to about 40% during the pandemic. And similarly, increase in mild symptoms, in moderately severe symptoms, and also in the severe symptom range. So the same population burden of mental health problems that's been described by the other speakers. We wanted to know what people would find helpful in a public policy response. And we asked about things like having a GP ask me about my mental health, or having face-to-face counselling with a mental health professional. And about a third of people said, yes, these would be very helpful. But by far the most strongly desired assistance was for the government to have a publicly available plan about management of future pandemics, which might be reassuring to them about government agency in responding to people's needs. And many people said what they wanted was actually financial support rather than other forms of psychological or psychiatric support. This map is a little hard to read, but I'd ask you just to focus on the colour distribution, that universally the plan about a pandemic preparedness from the government was what people wanted most. Women wanted a more broad range of specific mental health supports, including those related to their employment, and they wanted information, including digital information, that would be helpful to them. But in this population, younger people felt they needed very much more support than older people did, and people in urban areas felt they needed more forms of support than people in rural and regional areas whose lives might have been less affected by the restrictions. The things that people did not want, they don't want their GP to ask them about their use of alcohol, which was quite a significant problem in Australia. And they didn't want particularly free access to mobile apps and online programs to help them manage their emotional well-being compared with these other public policies. So overall, what we documented was this population-wide shift in mental health, in that this affected both mild and moderately severe symptoms. And the most vulnerable people were people who'd lost their jobs or lived alone, experiences we've already heard about, or in the least well-resourced suburbs. But caregiving was a particular psychological burden for people who were caring for young children when the services like schools and childcare were closed, or who were caring for family members with a disability when the services for those groups of people were closed, or who were members of marginalised minorities. And more of the people with these experiences were women or were young people. And this population-wide burden is problematic for recovery because these problems themselves cause people to have less functioning efficiency, lower volition and drive, lower capacities to plan and organise and to engage with other people. So I think what this has taught us is that we need to broaden our conceptual framework to think beyond the notion of somebody being sick or well, and that probably what we're observing is a normal human reaction to very abnormal circumstances, and that these have challenged everyone's adaptive capacities in new ways, and they've also reduced access to the protective social relationships and opportunities for social and economic participation. Anxiety usually increases in circumstances of uncertainty, but particularly in this circumstance, because there was no clear endpoint. So the vigilance and uncertainty really has continued for a very long time, and I think contributed to these. I think we have to remember also that depression arises in circumstances where people feel humiliated and entrapped. And these were intrinsic. The entrapment was clear with the restrictions. But if on top of that, people's circumstances were worsened because they were single and lonely or because they'd lost a job, there were elements of humiliation that went with this that contributed to the problem. Many people experience profound disenfranchised losses. These are losses that are not publicly recognised, but losses of autonomy and liberty, loss of employment, loss of engagement with others, but especially difficulty in being with family members during major life transitions, being unable to support people at the end of life, being unable to be with family members when new children were born, being unable to celebrate major milestones, were all experiences that people described as being psychologically harmful. So while I think the things we've heard about today are incredibly important, the digital tools to assist people, access to helplines and others, and opportunistic ascertainment of mental health in primary care, especially for the most vulnerable, people who are living alone or have lost jobs. They're things that definitely need to be attended to. But I think we also need a public mental health approach, which includes strategies for the whole population. These can be low intensity responses, but that we really need to think about public policies in non-health sectors that are highly relevant. And I think these are things like financial subsidies for people who've lost jobs or who are dependent on government benefits, policies about the importance of maintaining things like social bubbles so that people could have access to others even during the pandemic. And in our country, much more efficient access to vaccines than we actually had. We took a long time to make these available. So I'm interested to discuss these findings with you, and I'm very grateful to my colleagues who contributed to this work, the people who supported it financially, and especially the 23,000 Australians who contributed their experiences. Thank you very much.
Thank you. Thanks so much. I'm impressed by the huge sample you got, and over two different time periods. So let's go to a couple of questions. So one question, start with Benny, says you tackle a sensitive and critical topic I know the study was targeted for certain populations in Java, but do you think that these results might be generalizable to other populations there in times of COVID?
Yeah, thank you for the very quick questions. Actually, yes. If when it comes to vulnerable populations, yes, there are so many similar findings everywhere. But unfortunately, our study was very limited because especially when it comes to elderly or other kind of other people who live in other island, because we only use such online method that may not be as really accessible for some populations. But yeah, I will argue that the findings for vulnerable populations have higher mental health issues, just like what Dr. Murthy has presented as well, that they also have these kind of findings everywhere around the globe.
Thank you so much. Let's see, another question has to do for Dr. Fisher with mental health professionals. So for healthcare workers, I think in general, has their mental health been worsened by the pandemic because they're unable to support people because either they're sick themselves or it's just kind of overwhelming?
I think this is a really good point. We know that there were very high rates and growing rates of burnout among health professionals who were fatigued and cynical and dispirited by the constancy of their work. Certainly among mental health professionals, many of them have described that they themselves were affected by these circumstances. They themselves were trying to homeschool or look after someone with a disability or have difficulty in accessing the care they needed in intimate relationships. And so it was very hard for them to be optimistic and encouraging to others. So I think the needs, the psychological needs of mental health professionals were probably not adequately attended to. And I think in a future pandemic that support for them, mentorship and encouragement is going to be incredibly important.
Absolutely. I think I have a colleague who's also working on these same issues with frontline workers during conflict, like with the Ukrainian conflict, similar kind of trauma that they're experiencing.
Yeah, absolutely right.
Thank you. I think one last question for Betty. Do you know how the rates of suicide ideation you found in your study compares to studies of suicide ideation in other countries?
Yeah, that's also another interesting question. So when it comes to suicide ideation rate in different countries, they tend to be quite different in different contexts. So some contexts have not so much suicide ideation rate compared to my study, especially, but they do have high depression rate. This might happen due to the structural support is still making them make sure that they still want to live another day. But then in other contexts where the structural support is not available and the aid is not even there, or in other situation, maybe the community support doesn't really exist, especially if they are in vulnerable population, then the higher rate is the suicide ideation rate is quite high. So yeah, again, back to their own context, to the challenges and the structural support is provided, the suicide rate will be quite different. But when it comes to vulnerable population, I believe in different contexts, they tend to have higher rate of suicide.
Thank you so much. Well, it looks like our time is coming to the end, but once again, I would like to thank our four speakers. You really highlighted in different contexts some of the, I think that some of the important issues that have come to light with the pandemic in terms of vulnerabilities and unique populations, and as well as policy implications and how we definitely need a lot more support. So thank you, applause to you all. And I would just like to show that if you're interested in this topic, our next webinar next week is assisting vulnerable populations in conflict situations. This is basically same time next week. We're going to be talking about acute conflicts like the Ukraine and Afghanistan, as well as policies to support post-conflict peace building. We have 4 speakers for that. If you're an instructor, we also have a webinar coming up in July for capacity building around teaching. So thank you everyone for joining us. It's been a real pleasure, and I've definitely learned a lot today. So thank you, and applause to everyone, our speakers. Thank you.
Thank you.
Thank you.
Have a
Thank
wonderful
you,
day.
everyone.
Okay, thank you. I know it's late for you there, Benny. Thanks for joining. Goodbye.
Bye.
Bye.